This is a short preview video of the lecture video on the topic sonography of renal cystic disease, available on the ultrasound educational website www.sonoshare.in. Short clippings of the various parts of the lecture video will follow. After listening the preview, if you wish to listen to the lecture video, please log in to sonoshare.in, register and subscribe and view the lecture video. Now, renal cystic disease is diagnosed recently. Now, renal cystic disease can be life-limiting or forms integral to proper renal and hepatic development. So, this ciliopathy is due to defects of primary cilia, affect wide variety of tissues, kidney disease, autosomal dominant polycystic kidney disease, nephronophthisis, and also the patient and the family, and of course follow-up of the disease where it is necessary. Now, protocol for renal cystic disease is ultrasound is the first investigation of choice, and CT MRI is not liver and spleen, and looking for corticomedullary differentiation and looking for cysts everywhere. And size of the cysts, we have to give the maximum diameter of the largest cyst. And cystic transformation of the intrahepatic bile ducts called the Caroli syndrome. And also in the females, internal genital pyramids whereby linear dilated tubules filling the renal medullary pyramid. So once this is seen, because it is a cyst containing fluid, there is acoustic enhancement which confirms that it is cyst, and this should not be connected to the collecting system child. Or it can be chelical diverticulae, hydrocalyx, pseudoaneurysm, cystic dysplasia examination, and at least one follow-up assessment has to be done after the diagnosis, and does not need contrast enhancement or tumor. Now, thin versus thick septum, the cutoff is 1 millimeter, and there is no flow in the septum. So that is followed up. Whereas and biopsy. A cyst, but the features will be thick irregular walls as seen here, area, and a larger cyst in the central echogenic area. This can be recessive polycystic kidney disease. Now, renal tubular acidosis, diagnosis of a condition, and second is a non-specific pattern where there are no point and there is no surrounding parenchyma. Then the diagnosis is multicystic dysplastic kidney. So these are the different. And a scan of the left flank shows the lower ported bile ducts and cysts. The incidence is 1 in 20,000 live births. There is no sex predilection. 50% of patients in the periphery, there is compression of the cortex by the enlarged renal pyramids, and the corticomedullary differentiation is lost because mainly that it is due to enlarged pyramids with tiny cysts as well as inversely related. So in the early present ARPKD, the polycystic disease of the kidneys and as well as cysts in the liver as seen here, and also rarely there may be cysts in the other organs, here liver cysts. At age 40 years excludes ADPKD. The dilated ureter medial to the cyst, and when you trace the ureter, you see a calculus. Ultrasound should be performed within 12 months after this cystic dysplasia. Now, cystic dysplasia may be isolated, and the conditions which are presenting a clue for this diagnosis, but at the corticomedullary junction are suggestive, and isolated renal unilateral or bilateral cysts, loss of corticomedullary differentiation, persistent distinctive cerebellar and brainstem defect described as molar tooth site, and on color Dopplers there is flow in the septa, leading to a diagnosis of cystic nephroma. Extending below the kidney, you may get a negative beak sign, reverse beak sign, and a heavy and genetic diagnosis is necessary in most of the conditions. When a genetic diagnosis is seen in Bardet-Biedl or increased echogenicity, and it gives the test gives a disease diagnosis. With a genetic diagnosis, recurrence risk can be counseled, which means. So lastly, acquired cystic and male to female ratio is 3:1, more common in males. Having gone through the preview, if you wish to listen to the main lecture video, go to sonoshare.in.